Now, Dr. Lucia Pelosini from Milano will deal about the calculation of volt in ICL. This is a very important topic because it's a continuous problem for refractive surgeons, how to expect to have finally the volt implanted in an ICL. Please look at this video because you will learn tricks and details about how to improve the predictability in calculating the volt.
Hello, and thank you very much for inviting me to present the vaulting variations after ICL implantation at the IRE meeting. The ICL lenses are available in 3 different models, and each model is available in 4 different sizes: 12.1mm, 12.6, 13.2 and 13.7mm length. The ICL has 4 foot plates that are placed in the ciliary sulcus, so that the ICL lens is compressed and bent, forming a curve. The vault is described as the distance between the posterior surface of the ICL and the anterior surface of the crystalline lens. So deciding the correct ICL size is critical to determine a satisfactory position and vaulting postoperatively. The ideal ICL vaulting is between 250 and 750 microns. If we have a very low vaulting, the ICL lens may contact directly the crystalline lens, increasing the risk of an early development of cataract. If the vault is too high, the lens will cause iris friction with pigment dispersion, possible uveitis and shallowing of the anterior chamber, with possible increased intraocular pressure, secondary angle closure glaucoma, and long-term endothelial cell loss. This is the first case. Is a student, 20 years old, with stable myopia for 5 years, -850 in the right, -8 in the left, with a small astigmatism. All the parameters were satisfactory. Fundus examination was satisfactory. Scotopic pupil around 6.6 mm. He presented high value of white to white and a very deep anterior chamber. And this is the anterior segment OCT pictures showing the depth of the anterior chamber, the surface of the crystalline lens. The online calculator of the ICL suggested an ICL size of 13.2 mm with a toric ICL for both eyes, -1150 spherical correction in the right and -11 spherical correction in the left, with a small cylindrical correction. On the online calculator, you will get the theatre planning showing the rotation of the ICL in order to align the toric axis with the axis of the astigmatism. Postoperative, the patient was delighted from the start. The anterior chambers was quiet, intraocular pressures were satisfactory with round pupils. The natural vision was 10/10. Patient very happy. But the vaulting of the lens was very high. It was over 1000 microns in both eyes. So this is the anterior segment OCT postoperatively. You can see the ICL sitting very high with respect to the crystalline lens. The iris is shifted forward. Anterior chamber is slightly more shallow. So the question is, what should we do? We are facing a patient who is extremely delighted about the result, is comfortable, pressure is normal, but we know that this lens has a very high vault. We have 3 options. Option 1 is to explant the lens and exchange with a 12.6 mm lens, a smaller length. Option 2 is to wait and review the patient with frequent reviews, monitoring pressure, anterior chamber, pupil diameter. If we had a spherical ICL, we could have considered rotation of the ICL, as we know that the ciliary sulcus has different sizes and space in different axes, and possibly a vertical rotation would have allowed a reduction of the vault. This was impossible because we had a toric lens, and in this case we decided to explant the lens and exchange it with a smaller lens. This is the second case. The patient is 43, -9 in the right, -13 in the left, with normal pachymetry, normal fundus and pupils. In this case, the values of white to white and anterior chamber were on the low limit. The anterior chamber on the MS39 resulted 2.6, but was over 3 with the IOL master. We felt that we were comfortable to go ahead but in order to increase the safety, we decided to do a preoperative YAG laser iridotomy. The recommended minimum anterior chamber depth from the ICL calculator is 2.8 millimeter. So this is the online calculation suggesting a spherical lens in both eyes, and the ICL size was 12.1 as suggested by the ICL online calculator for both eyes. The patient was reviewed postoperatively. The patient was happy, comfortable, extremely happy about the vision. Intraocular pressures were normal, but in this case the vaulting was extremely low or absent. So if we look at the anterior segment or CT of this case, you can see the ICL is sitting extremely low with respect to the crystalline lens. The anterior chamber is deep, pupils were round, pressure was normal. And the anterior segment is very quiet with well-centered ICL. Again, what should we do in this case? We have the option of explanting and changing the lens with a 12.6 millimeter lens, or option to wait and review the patient in order to monitor for possible movements of the lens or early onset of cataract. In this case, we decided to wait and review the patient carefully. We informed the patient that the lens had a position that was lower than expected, but overall we felt that it was safe to review this patient without further immediate intervention. So the correct selection of the ICL size is critical and results from correct preoperative measurements. The ICL is located in the sulcus of the eye, and the online calculator relies on white to white in order to predict the sulcus size. So we are not measuring the sulcus directly. We know that there is about 1% of cases of ICL requiring explantation and exchange. This was described by Camilla. And we know that ultrasound by microscopy, measuring the sulcus to sulcus distance directly, has a very high reliability in terms of postoperative vaulting. However, the ultrasound by microscopy is a difficult technique, not available in every clinic, and is very much operator dependent. Anterior segmental CT has offered many parameters, and there are formulas described using many other parameters, the NK, the KS formula, and these have increased the accuracy of vault prediction. Russo has described machine learning from preoperative anterior segmental CT, and again, this has shown an increased predictability of ICL vault and size. And finally, Reinstein has described the use of high-frequency digital ultrasound, measuring the ciliary body inner diameter and offering a very high correlation with ICL vault postoperatively. So in conclusion, we know that the prediction of vault and the selection of ICL size remains a critical factor in determining the success of the surgery. And we know that access to multiple diagnostic devices increases the accuracy of surgical planning. Thank you very much for the attention.